friends, welcome to my YouTube channel Dr. Arya's Vlogs. Today I am going to discuss part 4 of diagnosis and treatment planning in completely edentulous patients. In this lecture, I would like to include intraoral examination in detail. In intraoral examination, first and foremost, we have to examine if there is any teeth present. If any teeth exist, then we are planning for the various treatment options like immediate denture, overdenture, or single complete denture. Coming to mucosa, there are various types of mucosa like lining mucosa, specialized mucosa, and masticatory mucosa. And the mucosa of cheeks, lips, floor of the mouth, residual ridge, hard palate, and soft palate is evaluated for the color, thickness, and the condition. Color of the mucosa. Redness is a sign of inflammation which could be due to ill-fitting dentures, infections, smoking, and systemic diseases such as diabetes. It's important to eliminate the cause and allow the tissues to return to normal before impression making. And white patches and brown or blue pigmented spots should be noted. If the cause is uncertain, a biopsy is indicated. Thickness of the mucosa. The quality of the mucoperiosteum may vary in different parts of the arch. And the variations in thickness of mucosa makes it very difficult to equalize the pressure under the denture and to avoid soreness. House classified thickness of mucosa as class 1, class 2 and class 3. In class 1, normal uniform density of mucosal tissue approximately 1 mm thick. Investing membrane is firm but not tense and forms the ideal cushion for the basal seat of the denture. In class 2 mucosa, it can be of two types. Soft tissues have a thin investing membrane and are highly susceptible to irritation under pressure. And soft tissues have mucous membranes that are twice the normal thickness. And in class 3, soft tissues have excessively thick investing membranes filled with redundant tissue. Condition of the mucosa. House classified the condition of mucosa as class 1, which is healthy, class 2 it's irritated, and class 3 is pathological. Next one is residual alveolar ridge. We will discuss this topic under the following headings: arch size, arch form, ridge relationship, ridge forms, ridge contour, and ridge relation. Under ridge relation, inter-ridge distance, ridge parallelism, and positional relation will be discussed. Coming to arch size. It is classified into class 1, 2 and 3. Class 1, it is large and it is best for retention and stability. So greater the arch size, the larger is the contact and support, and hence the greater is the retention. In class 2, it is medium, good retention and stability, but it is not ideal. And class 3, it is small, difficult to achieve good retention and stability. So amount of basal seat availability, which is determined by the size of the arch. And more stability and retention is offered when the arch size is increased. Arch form, it is class 1, class 2 and class 3. Class 1 is square. It is the best form to prevent rotational movement. Class 2 is tapered. It offers resistance to movement but to a lesser degree. And class 3 is ovoid. They influences support and tooth selection. If opposing arches do not have the same form, the difficulty in tooth arrangement can be anticipated. Next one is ridge relationship according to angle. It is classified into class 1, class 2 and class 3. Class 1 is normal. Here the anterior segment of mandibular ridge directly below or slightly posterior to the maxillary anterior ridge. In this picture, it's clearly shown that the anterior segment of the mandibular ridge which directly below or slightly posterior to the maxillary anterior ridge. And in class 2, it is retrognathic. In this picture, here the anterior segment of the mandibular ridge retruded beyond the normal position. And in class 3, it is prognathic. Here the anterior segment of mandibular ridge protruded beyond the normal position. Coming to ridge forms. In maxilla, class 1 is square, class 2 is tapering, class 3 is flat. And in mandible, class 1 is inverted U-shaped or tall to medium with broad crest. Class 2 is inverted U-shaped, short with flat crest, and class 3 is unfavorable. That is tall thin inverted V, short thin inverted V, inverted W and undercut. So the maxillary ridge and vault form should be classified as class 1, it is square to gently rounded. It is most favorable, height resists lateral displacement. Parallelism of its sides maintains the seal to resist vertical displacement. Class 2 is tapering or V-shaped. Here V-shaped vault is there. Resists lateral displacement and vertical displacement breaks the seal. And class 3 is flat. Here it's a flat vault and resists vertical displacement and little resistance to lateral displacement. Coming to the mandibular ridge form. So first one is inverted U-shaped, parallel walls from medium to tall with broad crest. Inverted U-shaped, short with flat crest is the class 2. And class 3 is unfavorable, that is inverted W, short inverted V, tall thin inverted V and undercut. So next, coming to ridge contour. Ridges can be classified based on their contour as high ridge with flat crest and parallel sides. It is the most ideal form. Then flat ridge and knife-edged ridge. So the Atwood has classified the residual ridges as orders 1 to 6. It influences support and stability of the dentures. And the classification is order 1, it is pre-extraction. Order 2, it's post-extraction. Order 3, high well-rounded. Order 4, knife edge. Order 5, low well-rounded. And order 6 is depressed. Ridge relation. Under ridge relation, inter-ridge distance, parallelism and positional relation. Inter-ridge distance. Class 1 is ideal inter-arch space to accommodate the artificial teeth. Class 2 is excessive inter-arch space and class 3 is insufficient inter-arch space. So excessive inter-arch space will be due to excessive residual ridge resorption, and these patients will have decreased retention and stability of the dentures. And in class 3, that is insufficient inter-arch space, it will make teeth arrangement a difficulty. However, stability of the denture is increased in these patients due to decrease in leverage forces acting on the denture. So, increased inter-arch space which cause increased leverage forces. So, there is decreased retention and stability of their dentures. So coming to the ridge parallelism, this affects denture stability as non-parallel ridges will cause movement of the bases when teeth occlude due to unfavorable direction of the forces. And it is classified as parallel and non-parallel. Class 1, the both ridges are parallel to the occlusal plane. Class 2, this mandibular ridge is divergent from occlusal plane anteriorly. And class 3, maxillary ridge is divergent from occlusal plane anteriorly, or both ridges are divergent anteriorly. Next one is positional relation. This affects tooth arrangement and denture stability. As maxilla resorbs, the crest appears to move upwards and inwards. As mandible resorbs, the crest appears to move downwards, forwards and laterally. So this is the positional ridge relation, class 1, class 2 and class 3. Coming to hard palate, it is classified into U-shaped, which provides good retention and stability, V-shaped, which provides least retention, and flat, it provides poor retention and stability. Soft palate, U-shape, it is ideal for both retention and stability. V-shaped, retention is less as the peripheral seal is easily broken. And flat, reduced resistance to lateral and rotatory forces. Based on the degree of flexure that the soft palate makes with the hard palate and the width of the palatal seal area, the soft palate configurations can be classified into class 1, class 2 and class 3. So while examining soft palates, it is important to observe the relationship of soft palate to the hard palate. And the relationship between the soft palate and the hard palate is called palatal throat form. And on this basis, soft palates can be classified as class 1 soft palate, class 2 soft palate and class 3 soft palate. In class 1, it is almost horizontal with little movement making angle of less than 10 degree with hard palate. It is the most favorable and it allows best tissue coverage, that is more than 5 mm, and development of a wide posterior palatal seal. In class 2, soft palate makes a 45-degree angle to the hard palate, and class 3, here it makes a 70-degree angle with the hard palate. It is least favorable and it allows least tissue coverage, less than 3 mm. Palatal throat form. The House classified palatal throat forms into class 1, class 2 and class 3. Class 1 palatal throat form, it is large and normal in form and it is relatively with an immovable band of tissue which is 5 to 12 mm distal to a line drawn across the distal edge of tuberosities. So it is a large and normal in form, and here immovable band of tissue 5 to 12 mm distal to a line drawn across the distal edge of tuberosities. Class 2, it is medium sized and normal in form. Here the slit band of tissues 3 to 5 mm distal to a line drawn across the distal edge of tuberosities. And class 3, it usually accompanies a small maxilla. The curtain of soft tissue turns down abruptly 3 to 5 mm anterior to a line drawn across the palate at the distal edge of tuberosities. And class 3 soft palate is commonly associated with V-shaped palatal vault, and class 1 or class 2 associated with flat palatal vault. Coming to palatal sensitivity, it's evaluated by running a mouth mirror over the soft palate. Gagging is the normal defense mechanism to prevent foreign objects from entering the trachea. It is classified into class 1 normal, class 2 subnormal or hyposensitive, and class 3 is hypersensitive or supernormal. So, exaggerated gag reflex can compromise prosthodontic procedures like impression making, and the causes are systemic, psychological, physiologic and iatrogenic, and the management of such patients may be clinical, psychological or pharmacological. So the gagging can be controlled by careful handling of impression procedure, constant reassurance and diverting the patient attention from the procedure. Lateral throat form, it is the distance between the floor of the mouth and the middle of retromolar pad when the patient protrudes the tongue 1/4 inch beyond the edge of lower lip. So Neal classified the lateral throat form according to the extent of anterior movement of retromallohyoid curtain as tongue extended anteriorly. And it is classified into class 1 deep, class 2 it's moderate, that is any position in between 1 and 3, and class 3 is shallow. These are the classification of lateral throat form according to Neal. And here it is a customized instrument which is used to measure the depth of lateral throat form. Coming to border attachments, this is the height of attachment and this is the ridge crest. If away from the ridge, then good border seal can be achieved. So the border attachments can be classified into class 1, class 2 and class 3. Class 1, the attachments are placed away from the crest of the ridge and they are high in maxilla and low in mandible with relation to ridge crest, and there is at least 0.5 inches distance between the attachment and the crest of the ridge. Class 2, distance between the crest of the ridge and the attachment is around 0.25 to 0.5 inches, and in class 3, the distance between the crest of the ridge and the attachment is less than 0.25 inches. Frenal attachment, according to House, it is classified into class 1, class 2 and class 3. In class 1, high in the maxilla or low in the mandible with respect to crest of the ridge. Class 2, it's medium, and class 3, frenae encroach on the crest of the ridge and may interfere with the denture seal. And the surgical correction may be required. All the lingual tissues of the mandible are classified as muscle attachments. So saliva, quality and quantity of saliva are crucial factors in a patient's ability to tolerate dentures. Both the flow rate and viscosity are important to denture success. Normal resting salivary flow is about 1 ml per minute, and a flow of medium viscosity at this rate lubricates the mucosa and assists retention of complete dentures. Major salivary glands orifices should be examined to ensure that they are open. The amount and consistency of saliva affects denture retention and construction, and the amount of saliva can be classified as class 1 normal, class 2 excessive and class 3 xerostomia. So if there is a dry saliva, then the retention can be compromised and the potential for soreness. If there is excessive saliva, then it complicates the dentures reconstruction, especially in impression making. In quality, thin or watery type and thick droppy type. In thick droppy saliva, the denture wearing is more difficult. Okay, to check the consistency of saliva, we can use string test. Let's move on to the tongue. Tongue should be examined for its size and position. Tongue movement, muscular coordination and position control the dentures during speech, mastication and deglutition. Coming to the size of the tongue. Size can be classified into normal, enlarged and small. The presence of a large tongue which decreases the stability of the denture and it compromises the impression making, and the tongue biting is most common after the insertion of the dentures. And the small tongue does not provide adequate lingual peripheral seal. According to House, the tongue can be classified into class 1, class 2 and class 3. In class 1, normal in size, development and function, sufficient teeth are present to maintain this normal form and function. In class 2, the teeth have been absent long enough to permit a change in form and function of the tongue. And class 3, it is excessively large tongue. All teeth have been absent for an extended period of time, allowing for abnormal development of the size of the tongue. Insufficient denture can sometimes lead to development of class 3 tongue. Next, going to position of the tongue. The position of the tongue greatly affects the ability of a patient to successfully wear complete denture. According to Dr. C. Wright, he classified the tongue position into 3, that is class 1, class 2 and class 3. In class 1, the tongue lies on the floor of the mouth with the tip forwards and slightly below the incisal edges of the mandibular anterior teeth. That is class 1. Class 2, the tongue is flattened and also broadened, but the tip is in normal position. And class 3 is the tongue is retracted and depressed into the floor of the mouth with the tip curled upwards, downwards or assimilated into the body of the tongue. Class 1 position is ideal because in such a case the floor of the mouth is at an adequate height, hence the lingual flange of the denture contacts it and maintains the peripheral seal of the denture. But in both class 2 and class 3 cases, the floor of the mouth is too low. Hence, the dentist tends to overextend the denture flange. This will lead to loss of retention instead of obtaining peripheral seal because the denture flange impinges on the tissue and gets displaced during the activation of the floor of the mouth. In the first picture, for long-term edentulous patients, the intrinsic muscles of the tongue which may spread to fill in the extra available space, and this may cause various management and adaptation problems both during the fabrication as well as the patient's subsequent adaptation to the space restriction imposed by the presence of new prostheses. In the second picture, it shows a firm, broad and well developed ridge accompanied by a favorable tongue size and position suggests a good prognosis. Coming to TORI, Torus palatinus, it is found at the midline of the hard palate. Small ones can be accommodated by relief of denture base. Surgical excision if fills palate to occlusal level or extends beyond the vibrating line, and treatment deferred for 2 to 6 months. Mandibular tori, it is found commonly in lingual premolar region and it is difficult to provide relief without breaking border seal of the denture. Surgical removal is necessary for successful denture construction. Certain ridge defects like exostosis, which may pose a problem while fabricating a complete denture, and the redundant tissue that is common to find flabby tissue covering the crest of the residual ridges, and these movable tissues tend to cause movement of the denture when forces are applied, and this leads to loss of retention. So, there are various modified impression procedures for the flabby tissue. Next one is enlarged tuberosity. It may also associated with Kelly syndrome, wherein the anterior part of the maxillary complete denture rotates into an upward position while the posterior tuberosity part appears to grow downwards. This morphological predicament is usually associated with an untreated Kennedy class 1 type of mandibular dentition, and associated enlarged tuberosity may need to be surgically reduced to accommodate the replacement mandibular posterior dentition. Next is Epulis fissuratum. It may be due to various overextended flanges in the dentures. This is the papillary hyperplasia. Here it occurs on the anterior region of the palate in long-term denture varus, and often the tissue is inflamed and it is referred to as inflammatory papillary hyperplasia, and it is more prone to infection, frequently with Candida albicans, although the infection must be treated before new dentures are made. Recurrence is likely unless the hyperplastic tissue is removed. Coming to infection, various oral fungal infections are common in edentulous patients, particularly in maxillary denture related stomatitis, and concomitant inflammation of the corners of the mouth, that is angular cheilitis, should raise suspicions of Candida albicans infection. Then what are the investigations to be taken by the completely edentulous patient? Radiographic examination. So, panoramic radiograph, lateral cephalometry, and intraoral radiography. Any pathologies or any ridge resorption can be found out using the panoramic radiograph, and the ridge relation and facial profile can be assessed using lateral cephalometry, and to validate any suspicious areas specifically, then we can use intraoral radiography. So the radiographic images are necessary to ensure that abnormalities and pathosis are identified and if needed addressed before complete denture management is undertaken. So the interpretation of OPG, it can be used for any defects in structure or reactive new bone formation, then bone expansion, then any unerupted teeth or retained roots, then foreign bodies or radiolucencies and radiopasties, or maxillary sinus checked for inflammation, cysts, polyps and tumors. In the first picture, this OPG shows it identifies the superficial position of the mental foramina, while in A it shows the favorable ridge morphology and tooth roots in posterior maxillary regions. And the compromised ridge morphology is quite clear in picture B, together with superficially located mental foramina. Both the two-dimensional quantity of bone support, size and location of the maxillary sinus and the presence of an alloplastic only graft in the mandible are clearly shown in picture C. This is a typical example of the sort of scout view for selecting implant host sites before more sophisticated imaging is undertaken. So, the ridge resorption can be classified into class 1, class 2 and class 3. Class 1, it is mild resorption, loss of 1/3 of vaginal height. Class 2, moderate, loss of 1/3 to 2/3. And class 3, it is severe, loss of 2/3 or more. Coming to photographic images. So the pre-extraction photographs can be useful for determining the teeth selection and arrangement. Then diagnostic and study cast, it provides accurate information on tooth size and the arrangement, and assist in making decisions on pre-prosthetic surgery. And also the undercuts can be observed directly or determined precisely with the aid of a dental survey. So the completely edentulous patient, according to ACP 1999, it is classified into class 1, class 2, class 3 and class 4. Class 1 is ideal or minimally compromised. Class 2 is moderately compromised. Class 3 is substantially compromised. And class 4 is severely compromised. And the benefits of the system is better patient care, improved professional communication, better screening tool to assist dental school admission clinics, standardized criteria for outcomes assessment. So the diagnostic criteria include bone height, mandibular, then maxillary residual ridge morphology, mandibular muscle attachments, and maxilla-mandibular relationship. Here is a table showing diagnostic criteria in detail and the classification of completely edentulous patients according to ACP99. So in class 1, it's ideally or minimally compromised. Bone height, it is type 1, 21 mm or greater. Ridge morphology is type A. Muscle attachment is type A or B. Maxilla-mandibular relationship is class 1. In class 2, moderately compromised. Mandibular bone height is type 2, that is 16 to 21 mm. Ridge morphology is type B. Muscle attachment is type A or B. Maxilla-mandibular relationship is class 1. Then class 3, it is substantially compromised. Bone height is type 3, that is 11 to 15 mm. Ridge morphology is type C. Muscle attachment is type C. And the maxilla-mandibular relationship is class 2 or 3. And class 4, severely compromised. Bone height is type 4, that is 10 mm or less. Ridge morphology is type D. Muscle attachment is type D. And the maxilla-mandibular relationship is class 2 or 3. So coming to the development of a treatment plan, after all the intraoral and general physical and dental conditions have been recorded and radiographs, cast and other visual aids are in hand, they can be interpreted and the treatment plan can be developed. And the details of the specific observations determine the details of the treatment required. A primer on treatment options. They are adjunctive care and prosthodontic care. What is adjunctive care? Adjuvant therapy, it's also called adjunct therapy or adjunctive therapy or care, is a therapy that is given in addition to the primary or main or initial therapy to maximize its effectiveness. So it includes elimination of infection, elimination of pathosis, surgical improvement of denture support and space, tissue conditioning and nutritional counseling. And prosthodontic care is that it's for a patient destined to become edentulous and also for an edentulous patient. So for a patient destined to become edentulous, it is removable partial dentures, that is conventional, interim or hybrid complete denture or removable partial denture, and transitional. Complete denture, that is immediate or conventional, definitive or interim, tooth, implant or soft tissue supported. And for an edentulous patient, complete dentures, that is soft tissue supported, implant retained dentures, implant supported dentures, in implant supported, fixed and removable. Various clinical conditions that suggest the need for teeth extractions. Advanced periodontal disease with severe bone loss around the teeth, severely broken down crowns with subgingival residual tooth tissue that cannot be adequately restored, fractured roots, periapical or periodontal abscesses that cannot be successfully treated. Then coming to the treatment plan decisions. They are tissue conditioning or finger massage, that is type of treatment material and its frequency. Then pre-prosthetic surgery, that is procedures proposed and staging. Then the impression procedures, primary, final and the material used. And the jaw relation and articulator, that is spaceboard transfer, articulator and its control settings. Then tooth selection, that is shape, mold, material and number. And then denture based material. Why treatment plan? It addresses the patient's needs. It lists specific treatment, specifies logical sequence. It enables dentists to estimate the operating time, laboratory time, calendar time and fees. And thus enables patient to pay his informed consent, that is treatment, time and fees. And by estimating the operating time, laboratory time, calendar time and fees, dentist delivers the patient-specific delivered care. And thus patient receives delivered care through the informed consent. And next one is financial implications. Must consider the financial implications of any selected treatment plan. Optimal treatment plan is useless if the patient cannot afford it. Prioritize the need for different treatments based on the significance of identified problems. Treatment plan should balance the patient's needs and ability to pay. So coming to the summary for the treatment plan. It requires a broad knowledge of treatment possibilities and detailed knowledge of patient needs determined by a careful diagnosis. Treatment beyond the competency of the treatment planner should be referred to more experienced. The treatment planning must have a parallel process of developing a prognosis. Thus, the treatment planning can be summarized as the process of matching possible treatment options with patient's needs and systematically arranging the treatment in order of priority but in keeping with a logical or technically necessary sequence. So that's all about the diagnosis and treatment planning in completely edentulous patients. And here is a model of case sheet for completely edentulous patients. It including the patient data like name, age, OP number, race, then address, phone number, okay, then chief complaint, history of present illness, then the systemic status, any systemic disorders, then the patient's personal history, that is diet, habits, then the dental history, then any previous dentures are there, then earlier denture experience, pre-extraction records, mental attitude. The next one is the extraoral examination. In that, facial form, that is outline form, profile, then muscle tone, then lips, under lips length, thickness, support, mobility and commissures should be noted. Then the complexion should be noted. Then the temporomandibular joint, tenderness, mouth opening, deviation, clicking. Then the neuromuscular evaluation, speech and coordination should be evaluated. Then coming to the intraoral examination, arch form, Edwards classification of residual ridge forms, then the interarch space, ridge parallelism, ridge relationship, lateral throat form, then soft palate, then coming to mucosa, healthy, inflamed or pathologic, then mucosal or FRENAL attachment, then the saliva, that is quality and quantity, then tongue, that is size and position, or any other relevant details should be noted. Then the examination of all denture, then various investigations like radiographs, OPG, lateral cephalogram or any other. Then finally concluded with the diagnosis, that is class 1 ideally or minimally compromised, class 2 moderately compromised, class 3 substantially compromised and class 4 severely compromised. Then at last the treatment plan, that is tissue conditioning, pre-prosthetic surgery, impression procedure, jaw relation and articulator, then tooth selection, wax trying, denture insertion, post-insertion follow-up, then finally prognosis. Okay. That's all about the diagnosis and treatment planning in completely edentulous patients. Thanks for watching. Stay home, stay safe.